So I'm going to call to order the oldest Lions Club in the world. And if you stand, if you can, and we're going to do the Pledge of Allegiance and pledge to the Texas flag. And Alan Ford is going to leave us today. Now remember to mute yourself so that we don't have a bunch of people talking. We just want to hear Alan.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Honor the Texas flag. I pledge allegiance to thee, Texas, one state under God, one and indivisible. Yeehaw!
Thank you, Alan. Well, we have some guests today. I have two guests that I would like to introduce: Kyle Bennett and Kathleen Bennett. Would you wave?
Sure.
Happy to have you here today. Do we have any other guests? Okay. We have a couple birthdays coming up. Matt Ragsdale's birthday is on the 20th. And Mark Hastings is on the 24th. So I wish y'all happy birthday ahead of time.
Thank you.
Happy birthday, Eve, Mac, and happy birthday, Mark. So I don't know what
getting old.
I don't know what 5 days before your birthday would be, Mark. If it's Eve, Eve to the third power, Eve.
The Ides, the very, very Ides of my birthday.
Yeah, that's pretty much, yeah. With all the engineers.
I
and
thought that
architects
Mac's
here.
birthday was today, no?
It says the 20th. Is the calendar
Okay.
wrong?
That's a trick. I put May 19th on my Facebook page so that I would know who was finding out from Facebook.
Oh, wow. Wow.
The real one is tomorrow, yes.
Jeez. Another Texas loyalty test. You people are inscrutable, I must say. I just, I never would have thought of that.
Oh, gosh.
Yeah.
Okay. Well, I have several announcements to make, and I'm going to let Mac talk about our social this afternoon. Mac, would you clue us in? You're muted. Okay.
Yeah, it's been a while since we've gotten together socially, and so we're going to have a little spring fling here, 5:30 at Whole Foods Market on Lamar, and that's downtown there. Plenty of parking. Park down below, or there's some on the surface lot. Go inside, get yourself refreshments. They've got food. They've got a whole eatery court and a cafe, and bring it on upstairs. They've got an elevator inside, and they got stairs just outside the door that go up to this really nice roof patio. It's landscaped with trees, and hopefully there will be a little bit of a breeze this afternoon that would cool us off, and then we can stay there till 7 or 7:30 or whatever. Stay as long as you want. But for those who wear their dancing shoes, come on down to Don's Depot. Is a classic Austin watering hole that is right down the street. And Glenda will get some tables for us. And there's a live band starts at 9. Or there's a jukebox, and so come on down for some more socializing and fun. And I guess I wanted to offer that Robert and I split one of those. We had bid on the charity from the silent auction, the gift certificate at Don's Depot. So for the first people who show up at Don's Depot, we're gonna spin the whole thing, get a couple of pitchers of beer and share it around, or if you want a wine or a cocktail or something, come on down. And the first one's free.
Okay, I thought that, and I asked a while ago, but could I have a show of hands of people who are gonna attend?
You also had Gaylor with his hand up. I think he has a question, Glenda.
Oh, okay.
Mac, do we need to reserve tables or chairs on this roof patio?
No, we'll just go up there and make a lot of noise and stink the place up, and everybody else will probably leave.
All right, as
Okay.
usual. Okay.
It may not be a bad idea to bring, we've done it. We took our son up there. I have a great story. I won't bore anybody now, but tonight I'll tell it. They kind of have AstroTurf and some other spots, if I remember correctly. And so if it's comfortable, y'all might want to bring a beach towel or a blanket, just as a way of, getting 2nd-degree burns versus 3rd-degree burns if you sit on the on the AstroTurf. That's all. So, keep the Shriners from getting overloaded. So, it's kind of hot up there is all I'm saying. So, yeah.
You're not suggesting they don't have chairs, are you
Yeah,
saying?
well, I think they do, Gaylord,
They
but
do.
my only thought is, and if someone has been there in the last few years, I don't know if they took some chairs away because of COVID. I mean, some of these public spaces that you go to discourage social distancing, or people are just in the mood to steal chairs. There just seems to be a dearth of chairs. So I don't know, just something to be aware of. So.
Well, I
They
promise
do
you-
have, they do have some trees and shade and some little shade pavilions
Yeah.
and planters that are seating height. And I don't know about chairs or tables. I don't know about that.
You could probably bring a camp chair or one of those, one of those tailgating chairs if y'all are so inclined. So it's something to think.
Okay.
Sorry.
But I promise you, there's chairs at Don's Depot, so I'm hoping that
Yeah.
more of you come. It's a lot of fun. It's a lot of
Y'all
fun.
need to be boot scooting and not worrying about chairs.
That's right. That's right.
Uh,
Okay, I had one other thing I wanted to mention is we received an email that hospice is looking for volunteers. So if you're interested in doing some volunteer work for hospice, if you would just let me know and I'll forward that email to you. Do we have any other announcements today? Yes, Mark?
I do. I just put it in the, oh, Steve, good. I just put something in the chat about, while we were talking a minute ago, I was just glad I got on North Mopac, and they collect a lot of glasses, and they have been picked up in a while, and I just can't get out there because it's just too far. But I see Steve, you're offering to go pick those up.
Yeah, I got a couple of places on my route that are literally right around there. So
Great.
easy peasy. I should be,
Great.
in fact, I'll try and do it today. Patty, are you coming to the social by any chance? I don't know if Patty is, but I was going to say, I owe Patty one last delivery down to TS BVI anyway. So I'll just add this batch to it. So yeah, I'll
Okay.
get it today. Okay.
And she does suggest that you call before you come, but they're there pretty much, 9 to 5. So yeah,
Quick
good deal.
question, Mark. Do you have a
Yes.
name for me?
Oh, shoot.
Just
No.
chat it to me if you can. If not, I'll call them.
Yeah, I've got it somewhere else. I'll let you know.
All right. Sorry, guys. Thanks.
Thanks.
Any other announcements before we move into our program? Well, it's time for Alan Ford to introduce our program to us today.
Okay, first let me check. Dr. Giesler, are you about ready to go? Good, good. Okay. I met our speaker today almost 13 years ago. I had mentioned to my family doctor that I'd had a little discomfort in my chest on one occasion. And after a period of 2 or 3 months and some tests, I ended up having a little plumbing done on my heart. After the surgery, I was introduced to this young lady and told that I would be in her care as she would be my new cardiologist. And I have to admit, I was a little bit skeptical at first because she didn't really look old enough to be a doctor, much less a specialist. But she was indeed a graduate of UT Austin and UT's Houston Medical School, and she had completed a residency and a fellowship at the University of Cincinnati. And somehow it also eventually became the proud mother of 2 sons and the wife of another MD, Dr. Eric Giesler. Anyway, both my wife and I were immediately impressed with how she took the time to ask probing questions and to listen real carefully to my answers so she could treat me going forward. I've learned that a good cardiologist is as skilled an interrogator as any detective you could ever meet.
Mhm.
She treated me well and worked me really hard, and pretty soon I was in better shape than I had been in a long time. Then one day in about 2016, she just dumped me. Told me she'd been named director of a new women's heart program at the Seton Heart Institute, now part of Ascension Seton, and I didn't meet the requirements for admission. So she committed me into the care of another noted cardiologist, but not before taking a lot of time, as was her manner, to explain to me why there should be a special program for women and how what we learned from such a program could benefit men and women. And it was obvious to me that she had the right combination of professionalism and passion for that job. So that's what she's been doing since then. Fellow Lions and guests, please welcome Dr. Caitlin Giesler.
Thank you, thank you. Okay, now I need to figure out how to share my screen with you all. Let me see.
Do you need help guiding you or are you good?
Let me see if I guess I need some guidance,
You click on share screen at the bottom, the green,
right?
and then you click on the part, a new window appears. You click on the part that you want to share with us.
It's not popping up.
Is it open on your computer?
Yes. Let me see.
It should.
Okay,
You
okay,
got it?
I'll do it
Okay,
this way.
perfect. That's your whole screen.
Yes, now I have to.
Now you just need to move to the slides. Okay.
Okay.
There we go.
Thank you, Ellen, for the very, very nice introduction. I wish my two sons could have heard it. It would be nice for them to know that what I'm doing and when I'm working all the time. So it was very bittersweet when I had to change my practice a few years ago. But I did feel compelled and just drawn with this need and desire to improve the care of women in our community. And I'm going to go through a little bit of the history of cardiovascular disease in women and men in order to explain how we've come to the point that we need a women's heart center. And just as Alan said, how focusing on improving the care of women can also help men. I'm going to also just give a little bit of general heart knowledge so that we are all on the same page, you know what heart disease means, and then open it up to questions, which we can talk about anything you guys are interested in from a heart disease standpoint, whether it's statins, and when and if to take them, or how COVID affects heart, vaccines, etc. So I definitely want to leave some time at the end to make sure we're covering all the questions. But to begin with, the question is, if men are from Mars and women are from Venus, are our hearts different? As a matter of fact, they are, which has prompted me to direct and open this Women's Heart Center. Again, I'm going to go over this history of heart disease. And on this graph, it kind of gives an overview of why we started asking questions about men and women and heart disease. The red bar on the graph shows heart disease deaths in women, and the blue bar shows heart disease deaths in men over several decades. As you can see, the graph ended a while ago, but at that time, we were nearing significant improvement in deaths for men and women and had started to close the gap. The death rates, unfortunately, in both men and women are starting to climb again. And that is actually in younger men and women. So importantly, you can see that in the 70s and 80s, death rates were similar. And then we started getting really good at treating heart disease in men, and the death rate started to drop. However, we didn't see significant improvements in death rates for women until late 90s and early 2000s. So we're going to talk a little bit about that. When we talk about the important policies and the important dates that have occurred in this history, we need to talk about the Framingham Heart Study, which started in 1948 and actually included equal numbers of men and women. And this is the first study that's really looked at what causes heart disease. So they followed men and women in Framingham, Massachusetts for decades. And this is where we discovered that high blood pressure leads to an increased risk of heart disease. High cholesterol increases the risk of heart disease. Smoking, all of these risk factors that we're quite aware of were discovered with the Framingham Heart Study. In 1964, the American Heart Association had its first conference for women regarding heart, and this was the Hearts and Husbands Conference, where they invited women to come in and talk about how do we prevent heart disease in their husbands? What should we cook for our husbands, and how can we work to prevent heart attacks? So that was the intro for women in the American Heart Association. In the 1970s, there was a policy that limited including women in heart disease in any research trials, and it really followed the thalidomide effects. So thalidomide was a medication that women took when they were pregnant, often for nausea, and they noted that babies were born with birth defects associated with thalidomide. So in response to those outcomes, doing research in women, especially of childbearing age, was significantly limited starting in the 1970s. And that certainly had an impact on our awareness and knowledge about all kinds of medical issues and what is safe in pregnancy in general. We just have a paucity of knowledge. Finally, in the 80s, the FDA did recommend female participation in clinical trials. And in the 90s, Dr. Bernadine Healy led the NIH as the first female director. She was actually a cardiologist, and she was in charge of starting the Women's Health Initiative, which was a huge research investigation looking at health outcomes in women. And many of us remember hearing the initial outcomes of these investigations. This is where we found out that hormone replacement therapy can possibly increase the risk of heart attack in women. And even if it's helpful for bone health, it's not necessarily helpful and can be harmful in heart disease prevention. So this is when we stopped hormone replacement in every single woman who went through menopause. But we got a lot of good information about treating osteoporosis, breast cancer information, and kind of where the role of hormone replacement therapy may be helpful. So then in the 90s, there was an NIH inclusion policy written that said, if you're getting grant money from the NIH, you need to include women in your studies. It was written, but it was never actually followed. And finally, well, actually it was written in the 80s, but it wasn't followed until this policy was written and in the 90s. But even in 2010, the Institute of Medicine wrote a report showing women's health research still lags significantly behind the knowledge base that we have in men. And only about 23% of the data that we have for heart disease trials includes women. So we still had a lot to learn. And certainly these things had impacted our ability to test heart disease and other clinical issues in women. So we kind of go back to our graph. We can see, again, in the 70s and 80s, we're making great progress initially in treating men, and mostly that is improving awareness. This is, treat high blood pressure, treat cholesterol, and we make an impact on heart disease deaths in men. But we start seeing in the 90s really that there is this gap that is occurring. So women are dying more frequently than men of heart disease, and the numbers are climbing. You can see this black line in the middle of the graph. This is actually, again, when Dr. Bernadine Healy was in the NIH in the 90s doing the Women's Health Initiative. They also started the Red Dress campaign, which is the marketing and awareness campaign stating that heart disease is the #1 killer of women, and that more women are dying of heart disease. From the Red Dress campaign, which was the National Institutes of Health, the Go Red campaign was formed, and the American Heart Association has continued with that marketing awareness. But that made a huge impact on deaths in heart disease for women just by improving awareness. We noticed, though, even with improved marketing, the gap was still present. And so there was still more research to be done. And that is a lot of what I am involved in currently and actually implementing in my practice. So in the 90s, again, Dr. Bernadine Healy wrote an article in the New England Journal of Medicine to help explain this gap in death rates for men and women. And she postulated that there was a phenomenon called the Yentl syndrome. And it was based on the movie starring Barbara Streisand, where she, well, obviously the story of Yentl, but classically Barbara Streisand starred in the movie where she had to dress up as a man in order to be educated because only men could be educated. Dr. Healy thought, okay, if these women are coming into the emergency room with chest pain, shortness of breath, they're sweaty, definitely look like they're having a heart attack, except they're women, they don't look like men, and only men can have heart disease, then they're being dismissed and overlooked, and they're often sent home from the emergency room. And so part of what needed to happen was to educate physicians, all clinical practitioners, that women can in fact have heart disease, and that in order to close the gap, we need to improve awareness among women in the community, men in the community, but also among providers. So that helped close the gap somewhat. And they made a huge push educating providers, but still there were gaps in outcomes. Women were more likely to die following a heart attack. Women are more likely to have severe heart failure following a heart attack. And that we needed to figure out a little bit more. So in the meantime, we have done a lot of research on the differences between men and women. The main areas are social, which is including the fact that women are assumed not to be at high risk and therefore not treated aggressively. It's also difficult to do research on women because women are very often busy taking care of everybody else, and they have difficult time finding time to participate in trials and follow up consistently, so that some of the social demands have affected heart disease outcomes in women. The other thing that we have found is that there are biological differences, that pregnancy and menopause can affect heart disease and heart health in women, which obviously doesn't affect men. That women often have female patterns of heart disease. So the classic heart attack is a big blockage in one of the big main vessels of your heart. And that is a traditional type of heart disease, but very often women develop plaque throughout their blood vessels. So a lot of the testing appears normal, but they have true plaque. They're having heart attacks. They're just biologically different. And we're finding more and more that that is the case. However, it's not a zero-sum game. That is, many women have these atypical types of heart disease, but there are men that also have them. So the better that we understand these differences, the better that we treat men and women with these types of heart disease. And the last thing is that women often respond differently to medications and treatment. We found that women metabolize medications differently and so don't always tolerate the highest doses. 85% of the medications withdrawn from the market are withdrawn because of side effects greatly affecting women. So if we are lumping everybody together as we're studying medications and we find that they aren't very well tolerated in women, then men are also losing out on possible therapeutic options. So understanding the differences and testing men and women differently is important for both of us. Even in basic lab research, historically, they've used male rats because scientists didn't want to deal with pesky hormones in female rats. And again, that may be affecting the data that we're collecting. I wanted to show this chart in order to just remind everybody what are the risk factors for heart disease, and again explain some of the things that we've learned as we are digging into the differences. So we know that smoking increases your risk of heart disease, diabetes does, high blood pressure does, and of course high cholesterol. Also, men over the age of 55 are at increased risk, and women over the age of 65 are at increased risk of heart disease. What we have found in digging deeper is that autoimmune disease is a risk factor for developing heart disease. 90% of patients with autoimmune disease are women. Of course, there are certainly men with autoimmune disease, but a woman coming in with rheumatoid arthritis and perfect blood pressure and perfect cholesterol is still at risk of developing heart disease because of that autoimmune disease and the inflammatory nature. Also, pregnancy complications, which certainly affect women, are very important in increasing and giving it a window into vascular health and the future of vascular function. So a woman with preeclampsia actually has stiffening of her blood vessels from that event. And preeclampsia is when you suddenly have severely elevated blood pressures around the time of delivery. And the only way to get the blood pressure down is to deliver. These women can develop heart failure and complications from the high blood pressure. And again, they have lasting differences in their bodies after this episode that increase the risk of developing heart disease. High blood pressure in pregnancy. So sometimes women develop high blood pressure only when pregnant. That's also a risk factor for future events. Having preterm labor is a risk factor for developing heart disease later in life. And so is having gestational diabetes. Importantly, in my practice, if I have women who have this history, then I'm very aggressive with their traditional risk factors, and we're finding that it makes a big impact on their outcomes long term. Just this week, they published in the New York Times this article, which again just speaks to why we need to continue digging and why I do what I do. Heart disease in women is so often missed or dismissed. And it basically goes back to all of these things that we're talking about. And it starts with this history that we're starting a little bit behind compared to men. But I am sure that we can make it up and improve outcomes for women everywhere. And part of you all attending this and listening is important in that, because women need to advocate for themselves, but also men in their lives need to know that heart disease is the #1 killer of women. And that if you're noticing a difference in the way your wife, mother, sister, friend are feeling and acting, it's important to urge them to get treatment and addressed. Okay, I'm going to talk about what I mean when I say heart disease, because sometimes that's confusing for people. And hopefully I can get this to work for y'all. Can everybody see that big heart on the screen? Okay. When we're talking about heart disease, what we really mean most of the time is that there is blockage in the blood vessels feeding the heart. And so this is your heart if you're kind of looking out at us. So this is the left side of your heart, and this is the right side of your heart. But the blood vessels that feed your heart are these red arteries sitting outside on top of the heart. And those are the things that get blocked up. And that's what causes a heart attack. If this blood vessel is blocked, then the heart muscle below it is not getting adequate blood flow, and it damages the muscle. And so what we want to do is prevent that plaque or that blockage from building up over time. So this is a cross section of a blood vessel, and you can see that over time, or the early onset of heart disease is actually plaque buildup on the inner wall of the artery. So this is why you can have a heart catheterization or angiogram and everything looks normal, yet there is still plaque buildup because it's initially occurring in the wall of the artery. And that's what you can't really see from the outside. But over time, that plaque builds up and then it starts occluding the inside of the blood vessel. This graphic shows what happens in a heart attack. It's actually the plaque that's building up will suddenly rupture. And I always think about it kind of like a scab coming off where it ruptures and then there's this soft plaque that's exposed. And then what will happen is a clot will form over time in order to heal that blockage or that rupture, I'm sorry. So you'll go from maybe a 30 or 40% blockage 1 minute to several hours later having complete blockage. And that's what happens in a heart attack, is that this rupture of the plaque that's already existing occurs. And you have complete blockage and you get severe chest pressure and discomfort, and you call 911 and we bring you in and open it up. So in order to prevent that process from happening, we want to prevent the plaque buildup to begin with. And that's what controlling high blood pressure, controlling diabetes, controlling cholesterol, controlling your weight, making sure you're exercising and eating healthy, all of that really reduces your risk of developing the plaque to begin with, but it also reduces the risk of that rupture, that inflammatory process that occurs in a heart attack. Would it be helpful for you guys to ask questions at this point, or would you like me to go forward with some other anatomy?
Dr.
Go ahead,
Gaylor,
Gaylor.
yeah, could I ask a quick question?
Sure.
I've heard of cases where, and I am the least technical person medically you've ever met probably, but cases where the clot would break loose and maybe go to the brain and cause death or obviously other serious medical complications. Is that what happens or has happened? It was explained to me that that's what happened to a friend of mine, and I was just curious as to whether that's accurate, because I don't want to be repeating cause of death of a prominent friend if it's not correct, because that's what I was told.
So if this process, this plaque rupture and breakage occurs going to the brain, that's a stroke. So a heart attack is affecting the blood vessels of the heart, and a stroke is a brain attack. But it is a very similar process. So let me see if I can show you, well, carotid artery.
Then that's probably what happened.
These are the carotid arteries. Can you all see my screen here?
Yes.
So here's your brain, and then you have these nice big carotid arteries on either side of your neck. The exact same plaque building process can occur in your carotid arteries. And if a piece of plaque breaks off and goes to the brain, it can cause a stroke. And sometimes that can be deadly. The good news is the same preventative efforts that we use for heart prevention work for stroke prevention.
Well, and just to add to the question, maybe that's helpful to others. This was about the healthiest person I knew, except for the first, say, 50 or 60 years of his life, he was a smoker, but and a light drinker, but he quit smoking and drinking and exercised and had the healthiest diet imaginable. As I observed on Friday before he had the stroke that night and died a couple of days later. Can the effects of smoking from earlier in age have that effect as well as if you continue to smoke up until the time of the complication?
Absolutely. Yes, definitely. So the other thing is that this plaque buildup is an age-related process. It occurs over time. It's accelerated by smoking. It's accelerated by high blood pressure, diabetes, et cetera. But, there is some damage that's done from smoking in the past. So not stopping smoking can reverse it a little bit, but there is some damage that's done. And then time marches forward and your likelihood of developing plaque just over time period increases. The other cause of a stroke besides the plaque buildup, though, is atrial fibrillation, which is an electrical problem with the heart. And this is also a possibility. The thing with atrial fibrillation is you get this electrical storm on the top chambers of your heart, and that causes the bottom part of your heart to beat very fast and irregularly. But that electrical storm causes the top part of your heart not to contract normally. And you can have small clots of blood forming in your heart that will leave your heart and go to your brain and cause a stroke. Now that clot of blood is not made of cholesterol. It's not related at all to that, but it's coagulated blood. And that is a cause of stroke sometimes. The risk of complications from something like that is also higher if you have high blood pressure, high cholesterol, and you have narrowing of your blood vessels, but it's possible that that was related. So when we're talking about heart disease, again, normally we're talking about plaque buildup and blockages in those arteries outside of your heart, but we also deal with electrical problems where the electrical circuit in your heart isn't working properly. And then we have other structural heart problems where the muscle may not work properly.
Can I ask a question?
Sure.
And you partially answered it. My question was, can this plaque buildup happen in other parts of the body? And so you mentioned the brain and the heart, but can it happen just about anywhere? And also, whether it does or not, do we just hear about it because it happens to be in the worst possible place, your brain and your heart? And that's the place where it really matters.
That's exactly right. So yes, your whole body is a big tree of blood vessels. And interestingly, the blood vessels that feed your heart are the size of a piece of cooked spaghetti. So it doesn't take a lot of plaque buildup to cause significant problems. And right, your heart and your brain are your most vital organs. And so if there is any compromise in the blood flow to those organs, then it's very devastating. Versus in your gut, you have this huge network mesh of blood vessels. So there's a lot of collateral flow. If there is buildup or blockage, you wouldn't notice it unless it's quite severe. But you can have ischemic events in your gut, which means reduced blood flow. You can have problems in your legs. A lot of people with blockages in other places have claudication or PAD, which is on TV all the time. So it causes pain in your legs when you're walking. the really great thing about our biological design is that our carotid arteries are, the blood vessels in your brain have a circle and they collateralize themselves very well. So it takes a lot of blockage to have in your carotid artery to have a significant impact. It's so well duplicated. So really the heart tends to be one of the first places we find devastating episodes, but definitely it can occur anywhere.
I have a question.
Sure.
If I may. I had total blockage in my legs. And they did an angiogram where they put a balloon in my left leg. And then on my right leg, I went in for another procedure to have 2 stents. What is the risk of having the blockage come back again?
Well, as far as in your legs, it's not really high because the blood vessels in your legs are nice and big, like maybe the size of your finger instead of spaghetti. So it can take quite a while to get new blockage. But, when you get a stent placed, whether it's in your heart or your legs, you're just stenting a small area. And again, we have this whole tree of vessels. So if you had a stent in your left leg, then it's very likely there's some plaque buildup on the right or in other vessels going to your legs. However, being very aggressive with medications and lifestyle works. It really reduces the risk. So you can prevent it with being more aggressive on your numbers.
Thank you.
A follow-up question on AFib.
Yes.
It seems, and that's something a lot of us hear about, let's say, but there seems to be some type of immediate relief or treatment that reduces the threat of the AFib and the electrical problem you're mentioning. That's what I'd understood from people that have had that experience with AFib.
Mm-hmm.
Is there anything to that? How is there immediate relief if there's some kind of medicine that's immediately taken, or what kind of relief is there for one that's experiencing AFib?
Okay, so the thing with atrial fibrillation is it's a pain in the neck. It's like the bane of my existence because it's really uncomfortable for people and it can be difficult to treat. The thing with the problem, let me see if I can pull up some. So you can see on this graphic here, this is your normal heartbeat. You have this beautiful heart circuit that makes your heart beat every second. It starts in this top SA node of your heart and it sends this signal, and that causes your EKG to look like this. Very nice normal heartbeats. With atrial fibrillation, you just have this chaos in the top part of your heart where it's just a lot of electrical signals, and then the bottom part of your heart starts beating fast and irregularly. This is your AFib on an EKG. So this fast and irregular heartbeat is uncomfortable. Your heart's racing and it feels weird. So the treatment for atrial fibrillation is, number one, we want to slow the heart rate down. We want to get it more normalized and regulated. Then you'll feel better. And then we also want to reduce your stroke risk. And they're 2 separate things. We will put you on a blood thinner that will thin your blood so you don't clot it inside your heart, and that greatly reduces your risk of a stroke. But that doesn't help you feel better. The way to feel better is to get you back into a normal rhythm, or at least slow things down. So sometimes we will shock your heart back into a normal rhythm, kind of like on the movies where you, but it's a very controlled procedure. And we can also use medications that get you back into a normal rhythm or keep you in a normal rhythm. And then lastly, there's an ablation where we actually go inside the heart with catheters and we can burn certain areas of your heart where the AFib is coming from. So I'm not sure what the procedure or what it is that you've heard about, but there are a lot of ways to attack AFib. And I think the important thing, because it's confusing, how do you know if you're an AFib? What does it feel like? Usually you feel your heart beating fast and it's irregular. But sometimes if you're not sure, and if you have an Apple Watch, it's really good at detecting AFib and telling you what your EKG is. I think the tools that we have available now are amazing. If you are over the age of 65 and you're having a fast heartbeat or palpitations, you need to get it checked.
Thank you, because I've heard of a lot of instances, and who knows, I might be having it right now and I wouldn't know it, but thank you very much. That's very helpful. And your illustrations are extremely helpful.
I know, I love this. This is the American Heart Association. Their website has good stuff.
I have a question about cholesterol. You're talking about cholesterol. And the way I understand it, there's cholesterol in the foods, in certain foods we eat, but then your body also makes cholesterol. And my doctors, for years, my cholesterol is high, but they don't worry about it because my body makes so much of the good stuff that it throws the ratio that they calculate with the LDL.
Yep.
It throws the ratio off. And would you agree? I mean, is that correct, that I shouldn't worry about it?
Not necessarily. So for a long time, yes, I mean, definitely part of the reason that women have a later onset of heart disease is because we have a nice protective effect, probably of estrogen premenopausally. And what happens postmenopausally is our good cholesterol often goes down. We get stickier cholesterol and plaque builds up. But sometimes that high HDL can be misleading and it isn't always protective. So doing some kind of screening test to look at your blood vessels is really important. If you've done one of those coronary calcium scores, it's a CAT scan of your heart that is like the mammogram of your heart. It's great at telling you whether you have plaque buildup or not. If you have no plaque buildup, great, you are good to go. If there is plaque, then even you're not necessarily completely protected with that high HDL, and you need to be treated.
Thank you.
Alan, you have a question?
Yes, I do. First, let me just say I'm glad you mentioned atrial fibrillation, because you put me through a couple of courses of cardio rehab over those first 7 years. And I was surprised how many people were there for rhythm problems, because everything I'd ever heard about before had to do with artery blockage. So it was amazing. But my question really is, it seems like just 2 or 3 weeks ago, there was an article in the Austin American Statesman about some new collaboration to form another a Heart Institute type organization between Ascension Seton and, was it the Dell Medical School, or what? Can you tell us what that was about?
I don't have all of the details. This is in process. But I think, the vision is to grow the cardiovascular department within the medical school. And so there is, I don't know, there's not a whole lot to report, I guess. My group, which is part of Ascension Seton, is also involved with the medical school. So we're teaching the residents and the fellows, and we have research going on. But the next step is really to bring in more basic science research and to collaborate more with the University of Texas General School in order to really grow our understanding and knowledge base and research. So that's the plan. I think it means hiring some basic researchers that are interested in cardiology, but that is all in process. Rather than, I think, just what has been going on where we're working in separate silos, the plan is to bring all of these entities together and use the great power that we all have and potential.
Good, thank you.
Any other questions?
I have a question. I had coronary artery spasms. Is that particular danger?
It is, it's, that is actually very common in women, and it's something that I see all the time. The data is that there is a slight increased risk of heart attack compared to somebody who has no symptoms and no spasm, but it's less than somebody who has plaque buildup and has a history of coronary disease. So, however, I mean, what that kind of data tells me is that being aggressive, if you have high blood pressure, if you have cholesterol, reduces your risk long term, and we do know that. And so I think that's kind of the take home. Aside from treating the spasm itself and symptoms, that you want to be aggressive in treating the traditional risk factors.
I have a
Anything
question.
else?
I have a question if, sorry, with my.
It is lunchtime.
Next week, we'll have an etiquette expert. I apologize, forgive me, but I am eating tuna, so I'm trying to be healthy. My wife suffers from, what is it, hypothyroidism. And so I didn't know if there was a correlation between that. She's been on high blood pressure for a good while. When we had our son 11 years ago, she was at a threat for being preeclamptic, which is why we induced labor at 37 weeks, like literally on the day of. And I guess a second part is she had a procedure a while back where they discovered, I guess what they called an induced or an instigated pulmonary emboli as well. So I didn't know if that kind of stuff, does that give any kind of lasting damage to the heart, as it were, scar tissue wise or anything else, or does that add to it?
So as far as the thyroid disease, it does not accelerate plaque buildup and
Okay.
blockage and heart disease. I do see people with a lot of palpitations and extra heartbeats sometimes if their thyroid replacement medication is adjusted, but that's not harmful.
Okay.
And then, as far as like blood clots, that tells me that she should never be on hormone replacement therapy because that causes clots to form.
Right.
And so you just wouldn't want a clot to the brain or anything like that going forward.
Right.
But the damage, there's not going to be lasting heart damage from that. But having high blood pressure in pregnancy, you want to be really aggressive again. And like those coronary CT calcium scores are good in seeing where you are from a blood vessel, heart disease standpoint, and then treating the blood pressure the way she's doing.
And obviously prophylactically, just eating well, exercise, that kind of scenario. Of course, she was on Xarelto for several months, and then thankfully it receded and everything else. So
Good.
okay, thank you.
Yes, I guess I should be saying everybody needs to eat healthy and exercise. It does make a difference though. 30 minutes, 5 days a week, or 150 minutes of exercise a week makes a huge difference. I see hearts heal and normalize with it. It's really cool. And then you are what you eat. So anything you can do to eat healthy foods and feed yourself the good stuff makes a huge difference.
I think we have time for one more question.
I've got one more I think is important because I think we touched on the idea that because women's heart issues tended to involve the smaller arteries and things that they also might present with different symptoms. I think I've heard that before. Could you elaborate a little bit on how that might be?
It's like you're a plant. Yes, absolutely. So part of that Yentl syndrome was that, typical chest pain in a man or typical heart attack symptoms are chest pain, pressure radiating down the left arm, and it's severe pain, which honestly, chest pressure and discomfort is the number one sign of a heart attack in a woman also. But women also will often have pressure and discomfort radiating to the neck and jaw and to the back, and sometimes feel very nauseous. The big thing with any of these episodes is that you saw that plaque rupture. You're not getting good blood flow down that blood vessel. So it's not just a single pain or discomfort. It's usually a big constellation of symptoms that you feel like you're not catching your breath. You feel short of breath. You can get sweaty and clammy. Most of those things happen most of the time. And whether the pain is central and radiating to your left arm or central and radiating up to the neck and jaw tends to, be different for men and women.
Well, this has been very, very interesting. And I think we could all sit here and ask you many more questions. And, but I think we need to move on and talk about our program next week. Thank you so much for your program. And I think it was very helpful. Really appreciate it.
Thanks, you guys, for having me very much.
Greg, would you tell us about next week's program? Is Greg here? Okay, I guess Greg isn't here. Next week, it's going to be an in-person meeting. It's going to be at 11:45 at the school, and you need to please wear masks. And the the topic is the Victor Offender Dialogue Program by Tim Anderson. Sounds very interesting. And then immediately following the program, we are going to walk over to the pavilion and have a ceremony with our bench. So that would be very interesting, and I'm looking forward to that.
Thank you, Glenda. Sorry, I am here. It just took me longer
Oh.
than usual to find the mute button. So
Oh,
apologize. Thanks for covering that. Pastor Tim Anderson, I think you'll find him a really engaging speaker. He's written a couple of books about different things, and the topic he's going to talk about next week is called restorative justice. It's a great story and a great program in the Texas Department of Criminal Justice.
well, great. Well, that sounds like a good program also. And remember, next week, we will be meeting in person at 11:45 and to wear masks.
Restorative, okay. What does that mean, restorative justice?
I think that's what he'll talk to you about next week. That would be a great thing to learn then.
Okay. Well, does anybody else have anything to say before I adjourn? Oh, immediately following this, we're going to have a short board meeting, and I'll give you, 5 minutes to go powder your nose. But does anybody else have anything that they need to tell us or talk about before we adjourn for the day?
Oh, Beverly is asking something. So
Beverly?
she's muted. Beverly, you're muted, hon.
Beverly, can you unmute?
To unmute. There we go. Is that it?
Yeah, you're on.
Okay. Tomorrow, excuse me, not tomorrow, Saturday, we have eye screening at LBJ,
Yes.
and it's going to be 2 groups.
Yes, they'll be in two sections. It's from 11:30 to 3. And Robert, can you address that? Unmute yourself and address that, please. Unmute yourself, Robert. Unmute yourself, Robert.
There we go.
Okay.
We have 2 groups, Beverly and Sid and Chuck and Tommy will be the first group, and that will be from 10:30 until about 1 o'clock. And then at 12:30, myself, Ann, and her new installee, Lisa, will be there and take over till 3 o'clock, and then we'll wrap it up. So the location is at 7309 Lazy Creek Drive. And that's over on the east side of town, east of
Is
third.
that LBJ,
How's that?
LBJ school, high school?
LBJ High School, yes.
Okay.
Yep. And if there's any other questions, just speak up. But if I'll be phoning you just to confirm that you've got all the information and so on. So
Okay,
anyway, that's good. I appreciate it. Thank you.
thank you.
Two other things under important dates. Of course, the screening this the 21st, and then June 10th, we're going to serve refreshments at the Texas Lions Camp. And then June 24th to the 28th is the Lions Club International Convention in Montreal, Quebec, Canada. And then September the 9th is clay shoot. So these are things for y'all to be thinking of. Okay, then I'm going to adjourn this meeting. And as I say, give you about 5 minutes, and then we're going to come back for a board